In the previous class, I talked about preoperative consideration and evaluation of bone, and today I'm going to talk about treatment plan decision. Treatment plan decision. First, look at the length and diameter of the implant to be placed. Placement position and angle, number of implants to be placed, whether it's going to be 1 or 2-stage surgery, loading. In the case of interior, whether you're going to use temporary or not. They all need to be assessed. They're all important, but in my opinion, appropriate implant placement position and angle is imperative in getting accurate implant position and crucial to long-term prognosis and stability. Fixture length. During the days when we used Browning mark system, long fixture was favored. 13 mm or longer was considered to have high success rate. It was machined surface, and the longer the implant, the better stability was achieved. However, according to ITI, the literature says that 8 mm, 10 mm, 12 mm, as for long-term survival rate, there was no significant difference. Different surfaces have been developed, so it no longer makes sense to place extra long implants. In summary, in my case, I don't think you need to place a 13 mm or longer implant and cause bone heating. In my opinion, 10 mm or 11.5 mm implant is acceptable. In different areas, the recommended diameter is over 8.5 mm. This is for implant stability. As you can see, there's sufficient bone, so don't place such short implant. If possible, place 10 or 11.5 mm implant. That would be ideal. In the past, Browning mark had moisture in them. So long implant was placed for good initial stability, almost 18 mm. However, this is unnecessary. If there's enough bone, as you can see, if there's sufficient bone with sinus graft, 10 mm or 11.5 mm implant should be placed. Next is implant diameter. If you increase implant diameter by 0.25, surface area increases by 5 to 8%. If you look at the surface area increase by diameter, if the length of fixture is consistent, say diameter 3.7, if it is 4 mm, there's 8% increase, 5 mm, 35% increase, and 6 mm, 61% increase. With the increase, BIC is improved and implant stability increases, but in patient mouth, there's not enough bony space, so you have to choose adequate size of implant. By area, the recommended implant diameter is as follows. On far left is for crown. Next, diameter at the cervix. Reference the thickness of cervix when you place implant. In summary, in anterior lower, cervix is 3.5 or 4.0. So in anterior lower, use under 3.5 for MS implant, in other words, one body implant. In upper posterior and lower posterior, the molar region, there's most logos there. If possible, 4.5 to 5.0. I think 5.0 diameter implant should be placed. for rest of the area, I think 4.0 millimeter implant should be ideal. If bone thickness is sufficient, even for premolar and canine, 4.5 millimeter implant can be placed. 58-year-old male patient. In 2015, the patient had extraction and implant and prosthesis was provided immediately. Implant was placed right after extraction, so it was placed deep, and for initial stability, long implant was used. 2 years into prosthesis, around May, there was screw loosening, and multiple times thereafter, screw loosening occurred. It seemed odd, so I removed the crown and took x-ray. As you can see, there's tearing in fixture. In other words, there was a fracture in the fixture. Fortunately, there was a kit for removing fixture, and right after that, I used a 4.5 millimeter implant, two of them, which was a size bigger than the previous one, to finish the prosthesis. As you can see in the case, it was a male patient and the implant was placed deep. Crown root ratio was bad, and if it is a single crown, if there is sufficient amount of bone in premolar region, I think you'd be able to prevent the fixture tearing by choosing 4.5 millimeter diameter implant. Especially in the molar area, for implant stability, the minimum thickness for the US is 5 millimeter. In SS, 4.5 millimeter. On TS, 4.5 millimeter. In the molar area, at least you need to place this amount of thickness. Let's look at a case. Normally, when you place, you choose fixture diameter depending on the bone amount, number 25, and number 6 and 7. In number 25, there was not enough bone, and I chose 4.0, and for 6, which also did not have a lot of bone, I chose 4.5, and for 7, with sufficient amount of bone, 5 millimeter implant was chosen. Before surgery, I took CT and evaluated the amount of bone, and then chose the appropriate diameter implant. But everything has exceptions. As you can see, even though it is molar area, occlusal table, it's very narrow, so you should not choose 5.0, but you also need to consider distance with adjacent teeth, and you can choose 3 millimeter diameter and face no problems. Conversely, even if it is premolar, the distance is 9.1 millimeter. On average, MD diameter of premolar is 7 millimeter and molar is 10 millimeter. 9.1 means it's almost close to molar area. So in those cases, even if it is premolar, you can use 4.5 diameter implant. Let's look at implant position. Implant position in terms of mesiodistal or buccolingual aspects need to be considered. Let's look at the principle for mesiodistal implant placement. You need to place it so that it is in the center of final restoration, and the distance between natural tooth and implant should be at least 1.5 millimeter. Implant to implant distance should be at least 3 millimeter. As I mentioned, when you need a single implant, MD position should be at the center of where prosthesis is going to go. If mesiodistal distance is insufficient, you can do orthodontic treatment first to place the implant. If this is impossible, you can do enameloplasty to secure a bit more space. As you can see, there was a problem with number 3 bridge and retreatment was required. There was insufficient space mesiodistally, so orthodontic treatment was done to secure space and implant was placed. As you can see, number 25, ponic area, I wanted to place the implant, but orthodontic treatment was impossible. Enamelloplasty was done to secure space and implant was placed. That was how it was completed. Distance between implants. In external connection, if it is below 3 mm, horizontal bone resorption can occur and vertical height can decrease. In internal connection, if it is placed too close because of drilling heat, alveolar resorption can occur, so you need to maintain 3 mm distance. In order to get self-cleansing effect, you need to maintain 3 mm space. In number 6 and number 7, you can see that the implants are very close to each other and resurgery was required. We did surgery again after securing the space that was needed. In the most posterior teeth, it's very difficult to get mesiodistal position. When we try to get space, think about this. Molar crown's diameter is 10 mm, then center is 5 mm. In other words, in number 6, the position that's 5 mm from the distal, that's where you place it. Let's say the molar and implant distance is 2.5 to 3 mm. If you place 5 mm diameter implant, add 2.5 mm, and ideal placement should be 5.5 mm away from number 5. The next is buccolingual position. If you try to get buccolingual position, it should align with buccolingual center of adjacent teeth. And check whether this is normal dentition and also the occlusion with the opposing arch. Check whether there is sufficient bone in the imaginary entry point, and after we place it buccolingually, check if there is over 1 mm of bone on both sides. Buccolingually, there needs to be at least 1 mm or 1.82 mm of bone for long-term implant stability. In other words, buccolingually, there needs to be more than 1 mm of bone to place an implant. When you choose emplacement position, you always need to check occlusion with the opposing tooth. You need to be aware of top-down treatment planning. You know what this is. Top-down plan is, you think about the position of the prosthesis and implant should be placed at the center. This is the way to gain the stability of occlusion and implant. This is a necessary concept. Ultimately, we are doing it for prosthesis. For ideal delivery of prosthesis, so you need to place the implant at the center. So the position, in terms of this, you need to consider the length of fixture. It may differ from system to system, but the rough surface is ideal for placing within the bone. Rough surface should be placed 0.5 to 1 mm inferior from the bone, so that you be able to be more prepared for possible bone loss in the future. So 0.5 to 1 mm inferior to the bone, that's how it should be placed. As you can see, the top of fixture should be placed 0.5 to 1 mm below the bone. This is for long-term stability. When we consider placement depth, you need to consider biologic width. It's a way to protect inside from the outside. It's a soft tissue thickness to do this. You need approximately 3 mm around the implant. When you choose a placement depth, there needs to be 3 mm of biologic width, and minimum abutment length is 4 mm for a prosthesis retention. And if you add 1 mm of prosthesis occlusal surface thickness from the implanted tap to the opposing tooth, there needs to be 8 mm. In order to have emergence profile similar to natural teeth, you need 8 mm of space. Emergence profile is how prosthesis starts from gingival sulcus. From subgingival to supragingival, it is the shape of prosthesis as it transitions. In order for implant prosthesis to have similar emergence profile as natural tooth, you need 8 mm of space. The length of the mount is normally 8 mm. After you place the implant and connect the mount, you check the occlusion, and depending on how it is, you can assess the final placement depth. After you do occlusion, if there's no obstacle in mounting, you'll be able to gain over 8 mm of space. Clinically, I'll show you how to check the placement depths. After 7 months of extraction, there was sufficient amount of bone and it was posterior region. 5 by 11.5 implant was planned. In the case there is sufficient bone, below you can choose a drill that is a size longer. After you do placement, and on the buccal side, check if the rough surface is positioned below the bone, and check the lingual side as well, and also evaluate the occlusion. If the mount goes in smoothly, you need to check if 8 mm space can be secured. If there's lack of space, you need to place a little more deeply to secure that space. At final stage, remove mount. Check if the entire fixture is positioned 0.5 to 1 mm inferior to the bone, and if necessary, use fixture driver to adjust the depths. As mentioned earlier in the previous lecture, in the mandible posterior area, there's a lot of case where there's lack of space, so you need to place it a little bit deeply. Let's look at buccolingual placement and position and angle. Drilling direction should be considered from mesiodistal buccolingual perspective. In general, mesial tilting is required to resemble axis of natural teeth. The placement angle needs to resemble adjacent natural teeth, so you need to get that angle. As you can see, in the below case, mesial tilting is done similar to adjacent natural teeth, and prosthesis whole direction is in the center. However, if the mesial tilting is not done, the whole direction becomes distally inclined and cantilever effect can occur. So you need mesial tilting similar to natural teeth. It is the same in the upper area. In prosthesis with mesial tilting, the whole of prosthesis is located in the center. However, if it's not done this way, it can be distally inclined and occlusion may become unstable. Regardless of whether upper or lower, mesial tilting similar to that of natural teeth is important. From buccolingual perspective, the extended line from the implant should head towards functional cusp of opposing tooth. When you're placing implant in the upper, implant position needs to be towards lower posterior's functional cusp or buccal cusp, and when doing it in the lower, the position needs to head towards upper posterior's functional cusp, the lingual cusp. In the case of lower posterior, if you get the wrong buccolingual placement angle, as you can see in the lower posterior, there can be lingual wall perforation, and there can be damages to nerve or blood vessel. In the lower posterior, there's a concave anatomic structure. If you get the wrong angle, there can be lingual perforation, lingual artery, or arteria segmentalis can be perforated. As you drill in, you can cause damages to it, so you need to pay special attention. This is another case. Once implant is placed, the implant in the center needs to be changed. The direction needs to be changed. You need to pay attention to this. If you want to alter the direction, you need to remove it and do side cutting. Use a drill with a knife on its side and then place the implant. When you need to adjust the path, drilling is already done in that area, so final drill, in order to get good initial stability, you need to do under drilling by one size. The final drill, if you choose the normal size, the hole would get bigger. You would not be able to get good initial stability because drilling is already done, and if you want to adjust it, you need to under drill your final drill to get good initial stability. This is a tip when you're adjusting the path. Next consideration is the number of implants to be placed. In general, except for anterior, you place one implant for one missing teeth. However, in the anterior, you don't need to do it for every single missing teeth. So in upper anterior, you place 4 for 6 anterior, and for lower 6 anterior, you place 2. Depending on the patient's economic condition, you can also consider implant bridge. However, if possible, you need to avoid cantilever force, so implant position should be carefully thought out. So in the upper, number 4 and 6, and in the anterior, number 2 and 3 implants were placed. In the lower, I didn't place an implant for every single missing teeth, so I placed 2 implants and did a bridge, but you need to be aware of cantilever force. This has been the main content. I would like to summarize my lecture. Treatment plan decisions. You need to think of implant length and diameter. The length, as mentioned earlier, should be 10 to 11.5, and recommended diameter, you should choose length of 8.5 or more. The diameter, except for lower anterior, choose 4.0, and for the molar region, you can choose 4.5 to 5.0. You need appropriate placement, position, and angle. The position, you need to base it on top-down treatment and place it centrally. The depth should be 0.5 to 1 millimeter inferior to the bone. The angle should be parallel to adjacent teeth, and mesial tilting should be done. Number of implants to be placed. Except for anterior, you can place implant for every missing teeth. If you need to do bridge, you need to avoid cantilever design. Appropriate treatment plan reduces time, and functional and aesthetic satisfaction can be increased. Accurate position and appropriate depths can lead to natural and aesthetic results. Therefore, when you do treatment planning, you need to think of fixtures, length, diameter, position, and angle to get successful surgery results. You need to keep these in mind and apply them in actual surgery to get good results. What was not mentioned today will be addressed in offline lecture. Thank you for watching.